This conference will now be recorded.
Am I audible?
Yes, ma'am.
So today's topic is on hematuria, mainly concentrating on the PSDN part. But a brief introduction about hematuria I will show you in the first 10 slides, and later we'll go to the PSDN part. So coming to the hematuria part, uh, just to tell about the urine analysis microscopy, we take a 10 ml of urine and centrifuge for 5 minutes. So you can get the supernatant fluid and resuspend the sediment part in 0.5 ml of urine. Place it on a slide with a cover slip and count the number of RBCs in 20 fields. So you have to at least count for 20 fields and report the average. When do you call it as hematuria? If there are more than 5 RBC per high power field. So the definition of hematuria is in a urine analysis of microscopy. If you see 5 or more than 5 RBCs per HPF, then you can call it as hematuria. Later, you can count the number of WBCs, look for any CAS crystals, presence of any bacteria, yeast, parasite, and artifacts. So in these slides, I'll concentrate only on the hematuria. Not all urine that is red is hematuria. So as little as 1 ml of blood per liter of urine causes a visible color change. Pigments also color the urine. So when you see the RBCs in the urine, you describe whether it is a macroscopic hematuria or microscopic hematuria. Macroscopic hematuria is usually visible with your naked eye. The urine is pink in color, or the urine is red in color, or polar colored urine are the common symptoms which you can see. And microscopic hematuria, the urine is clear. You can identify the RBC only by the microscope and seen only under the microscope. So red urine, then you think it is a heme positive, and you take a dipstick which is positive. So what are all the conditions? Hematuria, hemoglobinuria, and also myoglobinuria. So you can centrifuge the urine next, and serum is separated. Look at the appearance. First condition is the urine is clear and the serum is also clear. So you'll go for a urine microscopy RBC greater than 5 per high power field, then it is hematuria. Second, if the urine is pink in color and the serum is also pink in color, urine microscopy, there are no RBCs at all. Add 1 ammonium sulfate to urine to make it clear, and the condition is hemoglobinuria. Third, if the urine is pink but the serum is clear, urine microscopy, no RBCs are found. On adding ammonium sulfate to urine, color persists, then that is myoglobinuria. So this is the way how you differentiate the hematuria and hemoglobinuria and myoglobinuria. Hematuria, both urine and serum are clear and RBCs are found only in microscope. But in hemoglobinuria, visible urine color is pink, but serum and RBCs doesn't show any significance. And ammonium sulfate, urine becomes clear, that is only hemoglobinuria. And both urine is pink and serum is clear, and no RBCs, color persists after adding ammonium sulfate, myoglobinuria. So red or brown urine with negative dipstick, that is all for the positive dipstick test. If it is a negative dipstick, a dye or pigment other than hemoglobin or myoglobin, first you have to suspect any dyes or external dyes or the pigmentation conditions. So pink, red, brown or burgundy color in beets, blackberries, nitrofurantoin drug usage, rifampicin, chloroquine, nitrofurantoin, deferoxamine, metronidazole, salicylates, ibuprofen, and urates. These are all the conditions causing your pink, red, or burgundy color urine. And dark brown or black colored urine seen in conditions like alkaptonuria, homogeneous aciduria, methemoglobinuria, typhinosis, melanin pigmentation, and porphyrias like porphyrin pigmentation. So hematuria, already we have discussed, more than 5 RBCs per microliter of centrifuge urine. You have a grass in upper tract and lower tract. The upper tract may be glomerular or extraglomerular. In upper tract, glomerular urine infection and all. In extraglomerular conditions of upper tract diseases, bright red urine is the condition seen. Urine is bright red with clots, then you have to rule out cystitis, urethritis, or any heavy exercise. So upper tract versus your lower tract hematuria. Upper tract bleeding, it is brown or cola colored, and lower tract, it is usually I have already told you that it's fresh urine, so it is usually frank lead color urine. And uniform color in upper tract bleeding, uniform colored urine and no clots. Where in lower tract there is non-uniform color urine and clots might be present, and it is already discussed red color gross hematuria. RBC casts are seen in upper tract bleeding and deformed RBC are seen. In lower tract bleeding, RBC morphology is usually eumorphic, and irritating voiding symptoms and strangury are present. Leukocytes or epithelial cell casts are seen in upper tract bleeding, and proteinuria is more than 100 milligram per deciliter in upper tract, where in lower tract the proteinuria is less than 100 milligram per deciliter. So first how do you differentiate them? By a 3-tube test. So we have to collect the urine in 3 tubes usually. First 10 ml or the first 5 ml is from the urethra, right? So the first test tube of urethra, second it might be anywhere, and the third last voided urine usually represents from the bladder or the trigone. So 3-tube test may differentiate. So causes of hematuria in glomerular causes, isolated renal and multisystem disease. When it comes to the isolated renal forms, you can have an IgA nephropathy or Alport syndrome and thin glomerular membrane disease, post-streptococcal glomerular nephritis, membranous nephropathy, and membranous proliferative glomerular nephritis, your FSGS and anti-GBM disease, and rapid progressive glomerular nephritis. And coming to the multi-system disease, those are usually connective tissue disorders like vasculitis, henoxin and purpura, hemolytic uremic syndromes, any multi-system involvement like HIV, sickle cell disease, and Goodpaster's disease. Coming to the extraglomerular causes, tubulointerstitial diseases and anatomic forms, hematological and vascular forms are differentiated. Coming to the first, tubulointerstitial diseases, pyelonephritis is common, acute tubular necrosis, papillary necrosis, nephrocalcinosis, interstitial nephritis. All your inflammatory forms of your nephritis, toxic nephropathy, other poisonous like poisons causing nephropathy, cortical necrosis, cystinuria, sickle cell disease, and idiopathic hypercalciuria. Your anatomic forms, polycystic kidney disease, multicystic dysplastic kidney, hydronephrosis, tumors, and your traumas. Hematological and sickle cell most common, coagular abnormalities, anticoagulation defects, and thrombocytopenia. All conditions like ITP or any thrombocytopenia condition, you can suspect a hematological cause. And vascular, arterial thrombosis, venous thrombosis, hemangioma, and aneurysms. So when we come to the renal disease common manifestation, when we want to rule out hematuria, we have to think about other conditions also, like presence of any edema along with hematuria, oliguria, urine volume less than 1 hour, less than 1 ml per hour per kg, and growth failures, and anuria, complete absence of urine, and dysuria. So all these conditions, why we want to ask? We want to ask whether that is glomerular or upper tract or lower tract. Presence of the hematuria, bright red or brown color urine, presence of edema, usually glomerular diseases, growth failures in RTA-like conditions, complete absence of urine or dysuria and UTIs or cystitis, anurias in glomerulonephritis, severe form of glomerulonephritis. So to evaluate, you have to ask about all these conditions, anemia and RTAs, rickets, renal rickets, you have to rule out hypertension and AGN, ureteric colic, any stones, renal mass, presence of multicystic or polycystic kidneys, flank pain in UTIs, and abnormalities of micturition. Even in UTIs, urgency, frequency are common. So to rule out, first you have to take all the common manifestations of your hematuria. So coming to the history next, when we suspect, like common conditions we are discussing, first let us discuss UTI, the third one. Then you have a dysuria. When you have an UTI, you have a history of dysuria, flank pain, sometimes renal colic might be present because of calculus. Any trauma like a bedridden child with in PICU, when catheterized, simple trauma, UTI causing condition, sexual abuse, previous similar episodes, recurrent UTI to rule out. And next is the PSGN, most common, post-streptococcal glomerulonephritis, the first one. So you have to ask about recurrent upper respiratory tract infections, any skin infections recently, presence of any headache, related hypertension and encephalopathy, presence of any headache, visual problems like papillary edemas due to encephalopathy, raised ICT, encephalopathy conditions, epistaxis, and epistaxis or upper respiratory tract infections, features suggest of the heart failure because of edema, they can CCF. So next is your hemolytic syndrome. You have a recent GI infection, fever with rash with joint pains and diarrhea, HSP or collagen vascular disease, henoxin and purpura. You have a maculopapular rash over the lower buttocks. Collagen vascular diseases may be associated with HUS, like any oral rashes or Goodpasture disease, and hemoptysis in bleeding diathesis. All this you have to ask, and family history of any hematurias. All the family members are having hematuria, like to rule out any benign familial hematuria, renal problems like single kidney, multicystic or polycystic kidney disease, and hearing problems. Your sibling with hematuria or AGN with hearing problem, you have to rule out Alport syndrome and renal stones. So when we come to the evaluation of hematuria, you assess for the growth failure, bony deformities, hypertension, failure and edema. So you have to assess all the things. And chromosomal abnormality, you can have low-set ears. Look at for the low-set ears, ear tags, supernumerary ripples. In ear tags, you can have syndromes like Alport's, and congenital anomalies like anorectal malformations, prone belly syndrome, single umbilical artery, and water. Water is your vertebral, anal, tracheoesophageal, and renal anomalies. Skin, purpura or anything seen to rule out HSP, neurocutaneous markers, or blood pressure, AGM like condition, serious gallop rhythm. Like presenting in CCF, we have a gallop rhythm murmur and raise in the like basal crepitations. Spinal and sacral anomalies, low limb deformities or wasting. Always look for distended bladder or velatable kidneys or external genitalia. These are all the physical examination findings. So your investigations, you'll take an urine analysis, hemogram with ESR, blood, urea, and serum creatinine. Do the RFT test. Glomerular hematuria, see the complement levels. Low complement levels are seen in streptococcal infections. AS1 anti-DNS, we are positive. ANA or ANCA creatinine clearance, look at the creatinine clearance. Extraglomerular hematuria, check your urine culture and sensitivity. Urine spot, calcium creatinine ratio, 24-hour urine oxalate, calcium, uric acid, and creatinine. So take a urine analysis of the first degree relatives also. So imaging, I'm not touching in detail. Ultrasound abdomen, hydronephrosis, renal scan you have to do. Urolithiasis, 24-hour calcium levels in urine and creatinine, oxalate, and uric acid. MCU, it is indicated in UTI. That is nothing but your micturition cystourethrogram. To rule out any, it evaluates the presence of any renal scars due to RPGN or MPGN. Hydroureter nephrosis and pyelophiliptasis. And radionucleotide scan, it is radiation, less radiation and sensitive part. DMSA, DTP, and MAC3 scans are usually used. DMSA to see the M for remember like morphology of the kidney, scarring of the kidney seen. DTPA for P for perfusion and function, free filtration and function. Remember like DTPA scan, and MAC3 is for the structure and function. These are the imaging for hematuria. And causes of persistent microscopic hematuria are your benign and familial hematurias, Alport syndromes, IgA nephropathy, idiopathic hypercalciuria, and thin glomerular basement membrane disease. So persistent asymptomatic isolated hematuria, that the child is having hematuria, it is only isolated, no other conditions are associated, and also asymptomatic but persistent. Need not do anything. Urine analysis every 3 months and annual renal function test. If it persists for more than 1 year, you have to do a detailed evaluation. So the indications of renal biopsy: persistent microscopic hematuria, presence of hematuria continuously, recurrent gross hematuria, hematuria with hypertension, severe hypertension, hematuria with significant proteinuria, and renal dysfunction. These are the indications of renal biopsy. This is how you want to evaluate your hematuria part. And we'll go to the PSGN now. Glomerulonephritis conditions. Is it visible for you?
Yes, ma'am.
So after doing all the evaluation for hematuria, you have to specially concentrate on the acute glomerular nephritis and post-streptococcal glomerulonephritis conditions. Uh, so this is the outline. In definition, you all know you are famous with this condition. Acute glomerulonephritis is characterized by abrupt onset of hematuria, presence of edema, hypertension, oliguria, and renal insufficiency. Any patient from any child with hematuria, edema, hypertension, and oliguria, I have to first suspect the age. Please mute yourself. If anyone is keeping your mobile on unmute form, please mute yourself. I'm hearing my voice as resound. Coming to the etiology of nephritic syndrome, you all know that is an previous infection of any throat or previous skin infections by nephrogenic strains of group A beta hemolytic streptococci. So beta hemolytic streptococci of group A with nephrogenic strains will cause this. The epidemics of nephritis has been described in associated with throat forms like seroforms or throat infections are your M1 and M4, M25 and M12, and skin serotypes are M49. Serotypes are much less important, but you have to remember the group A beta hemolytic streptococci. So glomerular inflammation and injury occurs due to it is an acute condition. First of all the inflammatory and injury conditions like acute AGN is a self-limiting acute and reversible condition. Post-infectious AGN can occur after streptococcal most commonly, or any other viral or bacterial infections, mycoplasma infections, or henoxinone nephritis. But streptococcal is the most common form. First presentation of chronic disease is your IgA nephropathy, membranoproliferative glomerulonephritis, your Alport syndrome, SLE, PAN, vaginal granulomatosis, and other chronic vasculitis. So pathophysiology. First, coming to the pathology part, the glomeruli are very much enlarged. You can see a mesangial cell proliferation. Polymorphic leukocyte infiltrations are seen. Crescent forms and interstitial inflammations are seen. And immunofluorescence. If you do an immunofluorescence microscopy, it reveals a pattern of lumpy, bumpy deposits of immunoglobulin and complement on the glomerular basement membrane and in the mesangium. So electron microscopy or electron dense deposits or humps are observed in epithelial side of the glomerular basement membrane, which we'll see in the picture. So this is the first one showing the hypercellular glomerular proliferation. Already we discussed with proliferating the endothelial cells and the mesangial cells and neutrophil infiltration. And the second picture showing the granular bumpy pattern of immune deposits on your immunofluorescence. This is the detailed picture. See the D is this is an electron microscope in a PSGN. The D is the electron dense deposits on the epithelial cell. EP is showing the epithelial cell. So the electron dense deposits on the epithelial cell side of the glomerular basement membrane. A polymorph nuclear P is present within the lumen. The P is the PMN cell within the lumen of the capillary. Bowman space, BS is the Bowman space, and M is the mesangium, which shows mesangial proliferation. So coming to the pathogenesis theories, some say it is a trapping of the circulating immune complexes in the glomeruli itself. So which we found is an autoimmune condition. Some say it is an autoimmune. Like the antigen is the streptococcal antigen, but when an antigen is present in your body, what happens regularly? Some antibodies are produced. The antibodies which are produced against the streptococcal antigen, instead of acting on them, they act both on the streptococcal antigen and in the glomerular tissue antigen also. So there are renal antigens in the glomerular tissue. There is a confusion and they both act on both of them. So the circulating antibodies are found in the blood against the streptococcal antigens. In situ, immune complex formation against anti-streptococcal antibodies and glomeruli also are seen. There will be activation of the complement system. These factors are your throat infections, which are seen mostly in the winter or early spring, pyoderma, later summer or fall. Overall risk of infection is 50%. Wherever the infection may be 50%, but after pyoderma, it increases up to 25%. So if it is skin or throat, overall infection is 15, and if skin is infected, 25%. Asymptomatic carriers, 20% are seen. May also occur even in the absence of any prodrome. Peak age group is the preschool children. Clinically apparent GN occurs in less than 2% of clinical infected with streptococcal. Your clinical manifestations are your abrupt onset of disease, age 4 to 12 years of age. Male is more predominant than female. Preschool and the school are the more targeted. Latent period is like after throat infection, 14 days, 1 to 2 weeks, 7 to 14 days, and skin infection is 3 to 6 weeks. Coming to the clinical features, hematuria, cola colored urine or smoky brown color urine. Glomerular clinical features of dysmorphic RBCs or casts in freshly spun urine. Proteinuria, mild to moderate, but nephrotic range is rare. Nephrotic is more than 4 grams per 24 hours, but it is lesser form. And oliguria and anuria are seen. Oliguria is more common. Edema, 85% of the patients have edema. You have periorbital edema or pedal edema, most commonly seen. Severe ratio, hypertension, it involves the multi-system in lungs, pleural effusion, and ascites. So it effusion and abdomen ascites, mostly like face and legs, likely face and legs. Hypertension, headache, altered mental status, convulsions, and papilledema, anorexia, nausea, somnolence. All this you can see in 80% of children. Hypertensive emergency in 10% only. Only 10% of this form fall into a hypertension emergency. BP greater than 30% for the age and sex. Evidence of any encephalopathies you have to rule out. Any pulmonary edemas and heart failures. It may land into CCF also. Agitemia of varying degrees and circulatory congestion. Dyspnea, orthopnea, cough, tachycardia, gallop rhythm, basal cramps, and pulmonary edema. Typical presentation is atypical presentation is your end stage, all end stage renal diseases, right? The hypertension is increased and leading to encephalopathy, leading to CCF, pulmonary edema due to most edema, renal end stage renal failures, and your nephrotic syndromes. Investigations. In urine, you have a dysmorphic or crenated RBCs and RBC casts. You have seen in hematuria and RBC casts, moderate proteinuria, mild to moderate. If it is more, again that is nephrotic. Only 10% can present like nephrotic, and it lasts for about 5 months. WBC or granular or hyaline casts are seen. When you take the blood, you have to take your serum, urea, and creatinine levels. You have to check the C3 levels, complement levels. So all the complements are already used in antibody formation. So you have to get a low complement levels in first 2 weeks, and it normalizes in 6 to 8 weeks. Serum CH50 levels of complement is also depressed, and C4 is more often normal or mildly depressed. AS4 titers are elevated in first week, second, third, fourth, fifth weeks. Consequently, they elevate after infection in 80%. By the fourth to fifth week, you can see a fourfold increase in normal, and the return to normal after several months. The best antibody titer to document your cutaneous streptococcal infection is the anti-deoxyribonuclease B level. So chest X-ray, as expected, you can see pulmonary congestion due to pulmonary edema, cardiomegaly. Tubular functions is preserved or mildly reduced. So coming to the differential diagnosis of your acute glomerular nephritis, you can have and decreased serum complement levels and normal serum complement levels. In the decreased serum complement levels like C3 and CH50, suspect first systemic diseases like lupus nephritis, subacute bacterial endocarditis, shunt nephritis, essential mixed cryoglobulinemia, visceral abscess, renal disease, and post-infectious GN and membranoproliferative type. So then you take an AS4 titer and evidence of anti-DNase B or streptozime test. If it is positive or return of low serum complement levels to normal by 6 to 8 weeks, then you suspect acute post-streptococcal glomerulonephritis. If it is negative, all your ASs are negative and anti-DNAs are negative, streptotype test is negative, and C3 complement levels fail to normal by 6 to 8 weeks, then you suspect other diseases like lupus nephritis, essential mixed cryoglobulinemia, shunt nephritis, visceral abscess, membranoproliferative bacterial endocarditis, and post-infectious, which is non-streptococcal. If it is streptococcal, your ASO should be positive, or streptozyme test and anti-DNA should be positive. So that is about when you see your decreased serum complement levels. When you don't see your decreased serum complement levels or normal serum complement levels, systemic diseases. Consider systemic diseases was PAN, hypersensitivity vasculitis, HSP, and good pastures. And renal diseases like IgA nephropathy, type 1, type 2, type 3 of anti-GBM, immune complex, and post-immune CGN, and post-infectious or non-streptococcal glomerulonephritis. So management, you already know what salt restriction and low potassium. Decrease your fluid intake to previous day. You keep an input-output chart, check your output, and output plus 500 to 600 ml per meter square. Keep an diuretic. Diuretic is the first drug to decrease even hypertension and your edema also. Furosemide or loop diuretic decreases the fluid overload, and automatically your hypertension also will decrease, and your pulmonary congestion and cardiovascular conditions are also lost. So hypertensive emergencies, you have to use calcium channel blockers, loop diuretics, or ACE inhibitors. So coming to the specific management, pulmonary edema, first you do the diuresis, give oxygen. If needed, you give a sedation like morphine and ventilate the child. Hyperkalemia, oral or IV restriction of the potassium binding resins. You give salbutamol nebulization and glucose or calcium infusion. That is the treatment of hyperkalemia. Dialysis, give a fluid overload. Severe azotemia or electrolyte disturbances, you can go for a dialysis. So daily, what do you want to monitor? You want to monitor your what is the edema percentage going for any respiratory distress or cardiac failure. So pulse and your respiratory rate. Look for the JVP and your BP. Fluid intake and output chart. So next day fluid you have to depends on the output chart. Take the weight of the child daily to see whether the edema is decreasing or not. Check the respiratory status. Check the neurological status. Hypertension, encephalopathy. You can see a decreased neurological status, and ECG if hyperkalemia is present or not. Biochemical, do a routine ultrasound, CUE, ALE, and RFTs and electrolytes. Most important is in your acute nephritis, your clinical diagnosis, presence of previous streptococcal infections, and immune mediated inflammation. RPGN, if these things are not much important, just I'm revising your rapid progressive glomerulonephritis, such as medical emergency, and progress to end-stage renal. Histopathological confirmation is most, and immunosuppressive treatment is recommended. You can do it by steroid, methylprednisolone, plasmapheresis, hemodialysis, and cyclophosphamide. So epithelial cell proliferation is seen in the Bowman's capsule, and crescent formation and compressing of the underlying glomerular tuft is seen. Outcome or prognosis, self-limiting, good prognosis, mortality less than 1%. By 7 to 10 days it recovers. C3 levels normals by 6 to 8 weeks. Hypertension and hematuria take some weeks to recover. Proteinuria may last for some months, and microscopic hematuria for years also. Renal biopsy is rarely indicated, and end-stage renal disease is less than 2%. Majority have a lifelong protection, and recurrent infection is low, and long-term follow-up is advocated. So what are all the indications of renal biopsy? If it is an MPGN, RPGN, or AGN, how do you indicate a renal biopsy? Already we have seen in the evaluation of hematuria, any atypical presentation. When the age group is in the adolescent, not presenting in the school or preschool age, nephrotic range of proteinuria. In nephritic, you have seen a nephrotic range of proteinuria in acute stage, and you have seen a normal complement levels. So all these are atypical, right? Or increasing RFT or the serum creatinine levels, ongoing proteinuria, long-lasting proteinuria and microhematuria, prolonged hypocomplementemia for more than 3 months, presence of azotemia, and associated symptoms of any other systemic like rashes, arthritis, any multi-system involvement, you have to go for a renal biopsy. Post-streptococcal infection, glomerulonephritis, and secondary causes. Like secondary causes like malaria or SL is causing hepatitis B infection, shunt nephritis, infective endocarditis, and associated with HSP. So it is an immune-mediated condition. Most common prototype is your post-streptococcal, self-limiting, or rarely progress to the end-stage renal disease. 95% of children recover. Pathology governs the treatment in atypical or severe cases. Outcome is variable, and specific treatment in secondary forms are needed. Like for SL, you have to treat immunosuppression, and collagen vascular diseases, you have to immunosuppress them. Thank you. Please save your chart. Those who have attended, please save your chart, and you can leave after saving your chart.